This is the C-Section Experience podcast, where we support you in preparing for and processing your C-section journey through education, validation, and storytelling. We're here to reduce anxiety, amplify your voice, and help you feel truly seen. I'm Dr. Jen, an obstetric anesthesiologist.
And I'm Bethany, a nurse and a birth educator. As friends and fellow C-section mamas, we're on a mission to empower you. Through personal stories and expert guests, we'll laugh, we'll cry, feel all the feels, so you can approach your birth with confidence. Are you ready? Hi, Jen.
Hi, Bethany.
We're going to finish off our conversation about retrievals. Episode 4 in particular, I really liked because obviously it wrapped up the whole conversation, but it has solutions in place for how this very important topic of intraoperative pain that women have experienced, what is the system that is changing to ensure that we are better supporting patients and preventing this intraoperative pain? How do you feel?
So you have more questions? Is that a question?
And that was just kind of a statement.
Yeah.
But my question is, so Heather Nixon talked about how she has a system in place now where every 15 minutes assesses the patient for what their pain level is. If it's above a level 3, she inquires more. Where's the location? What is the sensation that you're actually experiencing? And digging into more of understanding what this pain is and why it's happening. So as the anesthesiologist, she can fix it. What is your system that you have in play?
Well, definitely our medical record doesn't have that built in. I think she built that in. I just am always checking in with the patient constantly, especially before the surgery starts, to make sure I'm really confident with the block. And I don't think that problem of being overconfident, maybe to a fault sometimes. Like I am always second guessing everything. So I want to be really sure that what I did was effective and that there wasn't any issues with it. So I'm just like an over checker. That's just the way that I am.
Can I ask you if you were an over checker after you experienced a C-section yourself, or was this like has always been your practice?
I think I've always been cautious because I do this with labor epidurals too. I'm just really cautious. And I think as we see one thing happen one time, the more experience we have, the more people we take care of. I hold all of those one in a millions in the back of my brain. And I am a little obsessive about checking for them every single time. As far as pain, I think that's a great system in order to cover and not allow it to be missed by someone who may be more dismissive. But for me, I think my system is building a relationship with my patients from the beginning and explaining the way things should feel and connecting with them as much as I can so that I can sense when something feels off. And again, I'm checking in all the time and having conversations. If I'm interacting with them or if they're just chatting with their husband, I don't like butt in too much and let them have their conversation. But probably they're fine if they're chilling and having a conversation with their husband, right? I am looking for signs of distress, which could be anxiety sometimes. But whenever I see a sign of distress, I am really on top of how are you feeling? What are you feeling? If it's anxiety, I can help with that too. So let's talk through it. What are we really feeling right now? It's not so regimented of a system, but it's basically just communicating with the patient, staying on top of it, watching the patient, watching her face, seeing how things might change. If she's really relaxed in the beginning and then something changes, that's a red flag for me to investigate further what's going on. The communication is so important too, because a lot of times we're making decisions based on what we think the patient needs, and we need to know what they're feeling and what's important to them in order to make those decisions, basically.
Another part of the conversation that was so interesting is one of the nurses who was on the unit that day when her other nurse colleague experienced the intraoperative pain during her C-section, was she said, a lot of patients would prefer to be actually put to sleep, but it's not really something we offer to them. And why is that the trend versus expecting a patient to be awake during the surgery? And I kind of sat on that a little bit because I was like, but I don't know. I don't know if I feel
I
that.
disagree.
I disagree too.
Yeah.
I feel like most people
Totally disagree.
want to be awake
Yeah.
to have this experience, especially because, well, one, it's this like monumental moment that you're birthing your human, but also I wanted to be a part of it. I don't know if I would have felt as confident just being put to sleep and then waking up and meeting my baby and knowing that like I wasn't a participant. And so much of we talk about is like a gentle C-section is feeling that you are a part of this whole process and integrating gentle music or whatever music choice, maybe it's country, but all the things that you can have a sense of control over. I thought it was just kind of interesting that the nurse brought that up because I was like,
yeah,
really?
I just think that's not true. There are probably a few women that would prefer that, and those women should get what they want. And I think that's a fair thing to say. But I don't think that general anesthesia is the best option. And I don't think we should be presenting it as such. There are greater risks medically too, although they're not crazy. But there's a reason that neuraxial anesthesia is the best option. Medical reasons and psychological reasons. We should be improving the neuraxial anesthesia experience. We don't need to just say everyone should go to sleep. I think that was a fear-based comment. That
I
just
kind of felt
isn't
that
true.
Right. I kind of felt
No
that.
way.
So I'm like, well, isn't that where the history of anesthesia has worked towards from the 1950s, where it was just common practice to just put a patient to sleep? I mean, that's what you've been working so hard to change, is having that patient feel as a participant versus.
Yeah. And I think we just know, I mean, I think as C-section moms, as we have friends who have had C-sections, from all my vast experience taking care of C-section moms, like that is not. Would she say most women would rather be asleep, or a lot, or?
It was, why don't we like present that and ask that as an option? And I was kind of like,
I mean, yeah, it is an option. And that was, I guess, number one, we talked about last week, the guidelines was that to make sure that it's presented as an option, but it's not what's best most of the time. So certainly you can be supported, and we should do that for someone who feels like it's best for them. But women should be holding their babies right away, and women should be getting that time and having a pain-free experience and participating in their birth if they want to, which most do.
Yes. Yeah.
Yeah.
Okay.
I
I'm glad you
agree.
felt the same way with that comment. I was like, kind of sat on it for a second, like,
You're like, what?
I don't know. I don't think so. I don't have.
And personally, we both obviously don't feel that way.
No.
So that's why it's hard to, and I don't think that that's a common thing.
Okay. I think because that's going to be my other question. Like, have you ever had a patient where you went in to meet with them and talk through everything, and then they said, no, I really want to be put to sleep during this C-section? And how do you handle that situation?
I talk through their reasoning. What are their fears? I'm trying to think. I don't think I would never want to talk someone out of something that they have thought about and hopefully, made up this decision. I would say when someone has said something that bluntly, then I end up doing it with a discussion first, because it's totally within their right. And usually when people come to you with things like that are a little bit different, there's usually a very valid reason. And so we respect that 100%.
Right.
There have been people who are like, I was thinking like maybe it would be better. And they had a very clear fear that then I was able to make them feel better about. And then there's like, okay, never mind. I don't want to be put to sleep. I want to try the spinal anesthesia. So it does happen, but it's not super common.
Right. Which is why I like that not having the knowledge base of like why you're making a decision and understanding the pros and cons of each is so important to go into the birth space with the knowledge ahead of time so that you can have those proper conversations.
And everyone should know that it's not. I think as anesthesiologists, we just assume like obviously general anesthesia is an option. It's a surgery, but I guess that is something that we need to say a little bit louder for the people that it would matter to. And also just to know that if there is anything that isn't work with the spinal or epidural, that is, the answer isn't just suffer. It's you can go to sleep.
Right.
And that's something that you can do from the beginning as well.
So if the surgery, something goes awry in the surgery, that decision can be made. It's not like a black and white decision that needs to be made ahead of time. Unless they want it.
But I mean, I'm thinking about high risk cases. For example, placenta accreta are something that might require a hysterectomy or will definitely require a hysterectomy. So this is kind of a little bit bigger surgery, a little bit more high risk. Some anesthesiologists will say those types of patients need to go to sleep straight away. Other anesthesiologists will say, no, we can still do it under neuraxial. They can still participate, and then they can go to sleep if we need to go to sleep or not go to sleep if we don't. So those are scenarios where we're able to predict some complications or some reasons why we might need to go to sleep medically, not just because of pain, which shouldn't happen, but or because we're predicting that they might feel pain, which is not the goal, right? With neuraxial anesthesia, we should mention it, that it is something that we can either do because there's some complication or a failed other type of anesthesia, or because you want it.
Right. If the anxiety takes over and you're just not coping anymore. But it's an option. I feel like it was like that seemed to be a surprise for Suzanne that she could have, that was an option towards the end of the surgery. She then asked to be put to sleep when she knew there was still time.
Well, she wanted to be awake. So her goal was to get to the birth of her child, which she wanted to be present for. And the problem was that she was made to feel that she had to suffer, or that the suffering was normal. Whereas I think if she knew that suffering equals failed neuraxial anesthesia, your anesthesia has failed. And in that scenario, when you don't have an epidural, the only answer to get proper anesthesia is to go to sleep. But she didn't want to go to sleep.
Okay, another statement that I thought was very interesting that they said was, how many of us women have devoted our minds to suffering that originated in our body? And I kind of really thought on that as well. Like, how much suffering do we just endure as women and normalize? And that's why I think that the work that Suzanne has done to bring this all to really... Susanna, sorry. Sorry, I apologize. I'm all over the place.
I knew
with
you were
name.
Switching that up. Yeah,
I know. I apologize. Was that, to bring that to weight that, like, as women, why do we expect that, like, suffering is a part of life? I don't think men enter into that same realm.
It is for us in so many ways.
Right. Well, because you're like uncomfortable during pregnancy.
How about periods?
Well, yeah, exactly. Well, yeah, let's start back up when we were 15, maybe even earlier. And that was just like part of, it's like, oh, this
There's
hurts.
so many good comedy skits about this. There's one that was so funny, and just talking about hair removal, like all the stuff that we do as women that's painful, that men don't have to suffer through. And it's like preparing us for childbirth and all.
It's so true.
It's so funny.
It's so true. But it is. I feel like it's a part of our makeup that pain is just part of being a woman, which actually sucks. But I think it makes us stronger humans on this earth, is that we're able to endure it. But it's how we process it and how we feel supported with it and heard when we're feeling pain that matters so much. And I think in all these stories, the running narrative is they didn't feel heard, and they didn't feel that people were really respecting the level of discomfort and pain that they were experiencing.
And acknowledging it.
And following up on it. 6 weeks, 8 weeks after this, how did it affect your life? How did it affect your bonding with your baby? How did it affect your recovery? Because that all plays such an important part of this whole storyline of birthing our children, which is why I love in this new study, the SOLAR study, is that they're following up with patients within 6 to 8 weeks after their delivery to ask those questions and get those honest answers, and how therapeutic for that patient who experienced that to actually get to talk about it. And they're opening up that door for them to talk about it.
Yeah, I think it's going to be very interesting to see. And then, that's just a study, but then maybe from that study, we'll say, okay, actually, this is what we should be doing. It should be part of our note that we do before a patient leaves the hospital or after they get out of the operating room, is to ask that question. Did you feel any pain during your C-section? Even if you think the answer is going to be no, then just write no every single time.
Yeah.
That's going to be more, I think, a part of our culture, is being really sure, because somehow it seems that this does not get documented. It gets missed. More people are saying that they experienced it than maybe it seems providers are acknowledging. And so where is that disconnect, and how can we make it more obvious, and how can we then look at each individual case and say what went wrong here and what could have been done differently? And the more we do that, the more we look at each individual time this happens, the more we can learn to prevent it in the future. What is actually going on? What is actually the problem? Was it the problem with the testing? Was it a problem with communication? Was it a problem with the dosing? Maybe we're looking at, oh, well, that dose was maybe too low for this, or they didn't add any adjuvant medication to they just did plain local anesthetic without fentanyl or something. Whatever it is, there's a million different reasons, right? And we can gather all of that information if we're actually identifying these cases, and then the hospitals or the anesthesia groups or the OB groups are looking into it each time.
And you're not leaving a patient to just like sit on that information, because like when we spoke to Rachel Summerstein, and she was saying how there was such a gap between when she had her first and her second because of the experience with her first, and how that really made her sad, that like she was spending so much time processing that she didn't, like having another child was just not on her radar because she didn't want to go through that same experience. So if we're hitting these patients with questions at 6 to 8 weeks, maybe hitting it before that trauma like really sinks in so deep that it's hard to fix it. It's hard to curve it back to the other side where they trust their medical team again.
Yeah, it's about, we can't prevent absolutely everything from going wrong, whatever topic we're discussing. It's about mitigating it, because everything has a risk and a benefit. Like, sure, could we prevent intraoperative pain by putting every single person to sleep under general anesthesia, no matter what, no matter if they want that or not? Maybe, but then there's all kinds of other risks with that. Like, that's not the solution. There's no cut and dry solution, like just throw away neuraxial anesthesia. No, that's not the solution. The solution is to get better and better at dosing, at testing, at monitoring these blocks. And when something happens, because sure, there's always times when you're like, I did everything right. Everything was perfect until it wasn't. Then having the plans for like, what are we going to do to mitigate this trauma? Not make it so they're in that pain for such a long period of time. Shorten it up, tighten it up. How do we then address the patient afterwards so that she's not sitting on this and wondering and confused and thinking if something is wrong with her or whatever it is? Like, where can we, when things do happen, fixing as many of these scenarios as we can? And unfortunately, there just isn't one clear way to do that. It's a real combination of communication issues, technique issues, and putting it all together. I think awareness is really important. I think there are people who are probably testing their blocks a little bit more now, a different type of technique, this or that, because it's just being talked about.
Okay. So the trend is it's trending better. The awareness is there. The conversations are happening. Is there another SOAP conference coming up that you're going to be going to?
It's usually every May.
Oh, so are you going?
I didn't go last year, but
are you going to go to the upcoming one?
Yeah, I have to go. I felt really weird missing it last year.
Yeah. Well, you have to come back and talk about that because I'm so intrigued.
I wonder if you could go with me.
Oh, I would. Oh my God, I would love to go. But I think it would be so interesting to see like what that conversation is now from the last one that you went to.
Yeah.
You know, and in a
it's
short,
probably still somewhere. Yeah.
I mean, something that one of my professors said to me in nursing school that I'll never forget. She's like, I am so excited for your generation because you're going to see massive changes in medicine, more changes that I have ever seen. And that is something that has always stuck with me. And I mean, just integrating like holistic side into traditional medicine has like been like a really big push over, I think, the last 10, 15 years. People are gaining more knowledge about it and seeing the benefits. Even you, Jen.
I am. I am. I hate, it's just bringing up for me some things that are not really going well in medicine, which is the total abandonment of the scientific method and research and just the doctor bashing culture, which is coming up. And it's so unfortunate because it It's going to push people out of medicine. It's going to change our culture in not a good way. I mean, I'm losing a little hope on that front, I think.
Do you think that the doctor bashing is coming because there are these forums where people becomes a slippery slope of like someone says something and then like there's all this like chirping in?
No, I think it's because we're saying that like our recommendations are invalid and the things that we say cause diseases is wrong because people who have no medical knowledge think they know better. Yeah. It's just like a total attack on our expertise. It's a totally different topic because it's not really affecting the C-section world because C-sections are C-sections. And I don't think anyone's going to say, don't go see an anesthesiologist for your C-section or don't go see an OB for your C-section. I mean, it's just, in general, it's tough to work in this environment. It is. And it gets tougher and tougher. I don't know. I hope that things that we talk about serves to relay the complexity of things when we're talking about it really in depth. Because if you think that there's these black and white answers or someone else could do it better or we're not really thinking about this or it's easy or straightforward, like that's just not the case. It's really complex work that we do. And even for people who are really specialized in it and think about this constantly all the time. And remember, as anesthesiologists, this is like one little slice of what we do. We don't talk about management of OB emergencies and hemorrhaging and shock states and cardiomyopathies and all kinds of like complicated things that we also manage. We're just talking about really the experience during a C-section, but there's a lot going on that can't be oversimplified. I think there's just an oversimplification of medical topics that's spinning around, and it's sad.
Sorry. No, that is a bummer because you're right. It's like a lot of really good you don't want to lose good doctors because of that trend.
Right.
And you do put a lot of time and work and have put, I mean, can I just tell a story? One of my favorite stories, actually, when we first had become friends and I knew you were like a really good mom, was when you had just come home. So you had been over having a play date with Pippa and you had just gotten home from work. And I think you had been on one of your like 24-hour shifts. Like I knew you were really tired and Pippa wanted to play with you so badly and you didn't even take your scrubs off. You just sat down on the front porch and you started playing with her. And I thought to myself, you're a really good mom because the energy level that I'm sure that took for you to have a smile on your face, for you to give her that attention when I'm sure all you wanted to do was go inside, take a shower, go to sleep. You don't realize that a lot of doctors, like you are living two different lives. You still have to come home and be a mom and a present mom who cares about that little 5 minutes of playtime and everything to Pippa,
Yeah.
And I mean,
that was my whole life for so long.
I know
I
it
still
was.
can't believe I don't have to do that anymore.
And you never but you never my point is, but you never showed it. And I think that is the magical thing that a lot of doctors do is they are able to really control, like
Compartmentalize.
Exactly. You do that very well.
Yeah, and there's pros and cons to that, right? It's because we have to compartmentalize, but then you don't want to compartmentalize too much. There's a real delicate balance between you don't want to lose your humanity, but you also have to maintain your mental health. And there's this balance of should I go home and cry if something bad happened? Or can I hold it off for a little bit while I take care of my kid or whatever it is. But I want to wrap this episode up with 4 things that I think every mom preparing for a C-section should know. This is coming from, you mentioned the 2022 guidelines, but actually in the past few months, a lot of people are publishing papers that are sort of giving advice for why this happens, what information we need to know as the doctors to prevent it. And one of the things that keeps coming up is patient education and preparation. And how many people come in totally cold, just being like, what's going to happen to me? And what is it going to feel like? And having some expectations that might be really different than the reality. this one paper, I changed it a little bit, but there's basically 4 main things that women should know. And let me know if this is, just curious if you feel like these are like obvious.
Okay.
Or
patient hat on. I got it.
Put your patient hat on.
Got it.
And then I'm going to talk about it a little bit. So you will not, quote, feel nothing.
I think, no, I don't think that's a duh thing at all. I think that that's a really important thing.
Do you think some people are like, I'm not going to feel anything?
I do think most people think that, which is why we've had that conversation. They're like, I'm going to be numb. It's like, well, no, you're going to feel that tugging, that pressure. I mean, I know I've said this before. I will never forget each pregnancy, each delivery, the weight of the baby being, I knew the second my baby was delivered because I could feel that weight come out of my body.
And would you describe that as painful or uncomfortable at all?
No, I would not. It's neither word would I put to that. I would say it was almost felt like liberating. You just walking around with like an extra like
it's like the weight, a lifted weight.
A lifted weight. Yeah, that's what it felt like. It felt like a release.
I think the words that we choose are so important, and it's so tricky to describe this feeling. And we've talked about it a bunch, but I don't think you can ever talk about it enough.
I agree with that.
That there is no such thing as feeling nothing.
Right.
But the feelings should not be painful.
Right.
Or severely uncomfortable. And those feelings could include, I like the word movement. That's the new one that I've added that I think most people find very accurate. And you may even be describing movement when you're describing the lifting.
I would say that's a great way to describe it, is movement. Because movement doesn't make me feel...
It's not scary.
Fearful. It's like, okay, well, but if you actually think about it, of course there's going to be movement because movement is happening to get that baby out of your body.
Yeah. So pulling and tugging, yes, but I think that goes along with movement too, like the back and forth, the up and down, like the jiggling around, like things are like going on there, but it's not... I think those are still like pretty mild. What do you think about pulling and tugging?
I like that because I can like visualize pulling and tugging. Like you can't visualize, I like movement, of course, but like pulling and tugging, like everybody, like you can pull your hands apart, right? It's like something very easy that you can even practice. Like, okay, this is a pulling sensation.
Yeah.
This is a tugging sensation when your child's tugging
it's
on your
not like
leg
a
over
ripping.
and over. No.
And I'm adding tingling for the beginning.
I like that. Again, because everybody can associate, everybody's had like their foot fall asleep or your hand fall asleep. You understand what a sensation of tingling is, but still you're present that it is still there.
Yeah, right. And the pressure is we can't use it. I still use it sometimes, but I'm describing very specifically. It's like like somebody is like they're pushing on the very top, like with their hand. Mm-hmm. If they do that, they don't always do that. But like sometimes when people feel that kind of pressure of just like weight or pushing down versus like any kind of pressure that could be confused with pain.
Yeah.
I was also thinking about epidurals recently, and so maybe you can't relate to this, but there is a difference between like when you're about to deliver a baby and if you don't have your sacral nerves blocked and there's a baby coming out, like it hurts. It hurts a lot. If you do have those nerves blocked, like you'll just feel like you're about to poop. Everyone knows that feeling.
Yes.
And it's not like you're not like screaming in pain or like I feel like this like poop sitting in. It's like pressure.
Right.
But like that's the kind of pressure that's okay versus any kind of like painful.
Yeah.
I don't know. But so certainly you're going to feel something, but you shouldn't feel pain. No pain. Just no pain. That's it. This says use analogies like dental work where you feel pressure but not pain. Do you feel pressure in dental work?
Definitely.
Okay, the other thing that everyone should know is that spinals and epidurals can sometimes not work either partially or completely. There's various reasons. Sometimes we don't know why. Epidurals are more likely to cause a problem than spinals. I find, there's anatomical problems, scoliosis, things like that might be the issue. For spinal, sometimes it could be an anatomical issue or it could be just the placement was not in the right place or the medication dose was not high enough.
I don't think that's a duh one at all, because I think that on a lot of forms,
Some people just think it's like yes or no. Like, it'll work.
No, I don't.
Yeah. So I guess the knowledge that, and the reason why this is important is because it could be that, let's say your first spinal, it doesn't work for some reason, and then they do another neuraxial block, an epidural or something like that. So that's just to know that is like part of a consent process, something that could happen. And it doesn't mean that depending on like when it happens, obviously if it's identified, then you just may have to do another one. It's same with labor epidural. You get an epidural, it's possible that the epidural needs to be replaced. Third thing is that your block will be checked. I think your block was not checked. Your OBs checked it.
Right.
Or maybe anesthesia did. Everyone now, I guarantee you, anesthesia and OB are going to be checking blocks. So I think that's something to know, for the patient to know that we're going to check it.
Yeah, I don't think I don't think that's common knowledge that it's going to be checked.
Yeah, that there are ways to know how numb you are.
Right.
To what point in your spinal cord you are numb. We have various ways to do that, and we will do it.
Yeah.
And it's really anesthesia's responsibility, but the OBs also do their own little checks before they start. The last thing is, if you experience something that where you're not comfortable, where this is suffering, however you want to call it, pain, whatever, that there's things that we can do to fix it. So if you have an epidural, put more medication into an epidural. If you don't, it's IV medication. So that could be IV opioids. It could be ketamine. Ketamine I think is going to become out of favor too, but it is a possibility. If you just need a little bit, I think, of any of these IV medications, then obviously side effects are going to be fewer, and potentially it can get you through. You could be happy with the results, I guess. But if that doesn't work, which these things work very quickly, so that you should have your answer right away, then general anesthesia is always an option. So there's always something that we can do, basically. So if there's any issue with the spinal or epidural before, we can replace it. We can give more medication if there's an epidural in place. We can give you these IV medications, which there are certainly times when I've had to give IV medications, and it really does help with whatever tiny little problem was happening. Shoulder pain, for example, is something that I've never had to put someone under general anesthesia for shoulder pain, but those are nerves that we know are not blocked during our spinal. They're not supposed to be blocked. They're not going to be blocked. They come from the cervical spine, and also it's from your diaphragm, which you need to be awake. You need that diaphragm working to breathe. And so that shoulder pain, if you experience it, yes, we can treat that with IV, with medications to help you feel better. That's not something that we're going to need to put someone to sleep for. So if there was some kind of just somewhere little bit of discomfort, and we can get you through that, and then 5 minutes later you're holding your baby and enjoying your experience, fine, that's fine. If it's anything bigger than that, then we can put you right to sleep with general anesthesia.
There are options. And I think that's the biggest takeaway from this whole retrieval series is that the end result is that changes are being made. Changes can happen in the moment for that anesthesiologist to help you feel pain-free or to have some sort of solution for you. I like that it ended on not a fear factor, because that's what I was most afraid about when I first listened to the first episode was, oh my gosh, this is creating this waterfall of fear.
C-sections are this horrific, terrible experience.
Right. And
everyone should be asleep for them.
Right. And then I'm thinking, oh my God, how are we going to fix this, Jen? What have we been working so hard to do? Right. And so I was just so relieved at the final episode that she completed the loop. I think that also to that nurse getting clarity and understanding for
Susanna? Susanna's not the nurse, though. Clara.
No, I know. Clara got clarity and felt, that her story, the loop was closed.
She felt like something was being done.
Correct.
And that it wasn't being ignored, which is super important for healing, to know, what are we doing so that this doesn't happen in the future? And you're acknowledging what I went through. Yeah.
Yeah.
And Susanna really did do a lot especially because they did put her to sleep. It was just oh, well, sometimes spinals fail and we put you to sleep. Well, no. First of all, why is that test so confusing? Why aren't we identifying? How often are we not identifying a failed spinal? And how often are we not acknowledging it and saying the only answer to a failed spinal is to go to sleep? That's the only answer because this is too much. You're feeling literally the first incision, and taking on that ownership that it's not just about offering, but giving proper medical advice and understanding this requires general anesthesia.
Yeah. I have to say, I'm kind of sad that there isn't a fifth one. It's like really like I finished finishing a good book. You're like, oh, I don't want to get to the last page. But we got to the last page.
Yeah. I'm glad they're talking about it.
Yeah.
And I hope it doesn't come off as anesthesiologists being evil, torturers, dismissive. I guess I have thick skin about it. And I'm okay with always looking at our practices and always going back and saying, what can we do better? And I hope it doesn't create any more fear of the medical system than there already is. I hope it shows that we are thinking about this all the time and we are taking proactive steps, and it is complicated. And there are various things along the way in each of those stories that led things astray. And it's sort of like, where can we stop it when things start going astray? From the very beginning, from the very beginning, her testing was unclear. Why did she feel rushed? Why was the guy so confident in his block? It was just, a lot of things along the way. And for her to stand up and just say, this isn't okay, I think it's great. And I always encourage everyone to speak out and share your stories. It's what we all need to do because our end goal is all the same, which is to take care of people and do what's best for everybody. And sometimes we need to learn from the patients what matters to them. Because I will say there are times when things are more unclear than it seemed for Susanna. And I'm kind of recommending general anesthesia, and no, I really don't want it. And we're kind of having to go back and forth. And what should we try together? Like it's gotta kind of sometimes figure it out. It's not as clear as they kind of make it, as those two scenarios were, I guess.
We're evolving together as patients, doctors, nurses, LPNs, all the team. We're all evolving together to just try to get better and better and better. And that's what medicine is.
That's what it is. And so we want to keep hearing all of your stories, and we can highlight them on another episode.
Yeah.
Because I do think we all learn from hearing other people's stories and looking at what could have been done differently, what kind of information can we provide that might help sort some of these things out in the future.
Yeah. And if you tell us your stories, it's also therapeutic for you. Yeah. So it's a win on
Free
both
therapy.
sides. You get to go to therapy. We get to read your story. It makes us have another conversation.
Yeah.
And we keep going.
So do it.
Yeah.
Email us hi@csxpodcast.com or reach out to us at Instagram. The C-Section Experience is our handle. Anything else to say? Watch us on YouTube.
Oh, yes. Our YouTube channel. Yeah. Can see what we look like. And when we're doing all these hand motions, I talk a lot with my hands.
Yeah. You can see Bethany's boot if you want to see her boot.
Anyways, thank you guys so much for joining us.
Yes, we'll see you next week.
Bye.
Bye. We had so much fun recording this episode, and we hope you enjoyed it. Please reach out to us and let us know what you think and what you would like to hear about in future episodes. We would love to hear from you. You can email us at thecsxpodcast@gmail.com or follow us on Instagram at thecsxpodcast. We'll be back with more next week. Bye.